Just want to thank everybody for joining us. It is towards the end of the day for most of us. My name is Wanjiko Mangoyo, and I work for PATH. I'm a regional advocacy and policy advisor working there. I'm based in Nairobi, and today we are really excited because we are starting what we hope will be a series of conversations around primary health care. This is the first session, but essentially what we are starting is a learning webinar series where we're really looking at having a platform where we can learn and share and really discuss a lot of what is going on in terms of the policy reforms and how that is affecting how implementation of primary healthcare service delivery, implementation of the various policy reforms is going. So if we can go on to the next slide, what I will do is just provide an overview of what this series will look like. So as I said, what we're hoping to do is to just create a platform where we have stakeholders from across the health sector in Kenya to really reflect on the various ongoing policy reforms, to think through and to share really the experiences we're having when implementing primary healthcare, to share their adaptations in real time, to share some of the lessons that are going on across the country. What we're doing is we're having this co-convened with the Ministry of Health, the Council of Governors, and PATH, and we're hoping to bring in those critical insights from various stakeholders. What we're hoping that we will achieve really ultimately, the ultimate goal is with the series is to really strengthen our primary healthcare system by making sure that we are learning, that there is dialogue across the different stakeholders, that there is collaboration, and that this collaboration will drive effective implementation of national policies and will maximize the impact, the impact that we hope to have with the various reforms that are going on in the country. And ultimately, what we want to do is to make sure that we're improving access, quality, and also equity for primary health care services in the country. So what we had hoped to start off with is this first session. We have a series of sessions which we will share. But if we go on to the next slide. So what we're hoping with this very first session, which we're really excited to get going, is to really think about how do we accelerate implementation of the primary healthcare reforms in the country. What we're hoping to do specifically for this session is we want to provide an overview of what is going on in terms of the policy landscape and highlight progress and opportunities at national and county level. What we will always be doing with these sessions is showcasing various county experiences so that we are really drawing on lessons on what is working and what we can do to strengthen and operationalize our primary healthcare framework. And then we're hoping to also have a discussion with all of us on the call to really identify what are some of the enablers, the challenges, and the next steps to make sure that we're really accelerating implementation. What we will also do towards the end is we want to hear from you in terms of what you want to hear or learn about in future sessions. So this first session will be more of a little bit broader, but then we'll be diving into specific topics in depth, where we'll be either talking about financing or talking about the link with community health systems, or we'll be talking about the digital transformation. So what we want to make sure is that the future sessions that we have coming up really reflect the topics, the themes, the partners, the speakers that you want to hear from, so that it is, we're doing this collectively. So what we had hoped to do, let me check with the team working behind the scenes. We had hoped to start off with some welcome remarks from Dr. Lenai, head of the directorate. I just want to do a quick check to see if he has been able to log in, either himself or Dr. Salim. Is Dr. Salim on yet? Let me do a quick check here. Okay. So what we will do is allow them, I think they're having just a little bit, they're held up, but they will be joining us. So let's see, I see that they're still joining. I see that they're both joining. They must have just been held up. So if we can give them to the team working behind the scenes, should we give them a minute so that we can allow them to join in as people reflect on their objectives for this first session? I can talk briefly about what how we are hoping to structure these as they're joining in. So essentially what we're hoping to do is to be able to have these sessions every other month. So this is October, the next one will be in December. The December session, we're hoping to focus on the financing reforms. So, keep an eye out for that very sort of rich discussion. We will be doing this every other month. Again, this is a partnership between the ministry, PATH, Council of Governors, and then we want to make this interactive. Again, we want to be able to hear from you. We want to also make sure that we are hearing from across the country. So, for example, today we'll be hearing from Makueni as well as from Nakuru. But we want to make sure that with each successive session, we're really getting a good sense of what is going on the ground across the country, and not just from specific regions or specific sort of models for how primary healthcare is being implemented. So as I said, it's probably good for me to reiterate now, towards the end of the discussion, please, we will provide an opportunity to hear from you in terms of the themes and the topics you'd like to feature during this learning session. We would also like to hear if there's specific speakers who bring some particularly unique perspectives, or partners who are working collaboratively to really drive acceleration of primary healthcare on the ground. If there are other guests that you'd like to hear from, we will provide that opportunity towards the end. The other thing we will do towards the end is we will get a sense in terms of what timings would work for most of us on this call and how we move that forward. So I think in the interest of time, I am going to go ahead. I'm going to move the agenda around a little bit. As Dr. Salim and Dr. Lenai are joining in, we will save their remarks, but we'll go ahead and jump right into some of the county experiences that we want to feature, specifically starting off with Dr. Mwatha. So Dr. Mwatha, I hope you're ready. I know that I am putting you on the spot. So Dr. Mwatha, of course, is a country director for health in Makueni County. And so what he's going to do is he's going to share the county's experience with implementation. He's going to focus on really the approach that they have used in rolling out the PHC reforms. He's going to look at or highlight some of the achievements, the challenges, and some of the lessons. And really what we're hoping to do is, with the insights that he's going to share with us, it'll really help us to think about, what does this mean when we're talking about county level, county-wide adaptation and adaptation as well, and just essentially make sure that we are along this theme of accelerating implementation at scale. So Dr. Mwatha, are you on? Can we have you, do we have his presentation ready to share? And over to you, Dr. Mwatha, and welcome. Thank you very much.
Thank you so much, Wanjiko. I hope I'm audible.
You're loud and clear. Go ahead.
You're
Thank
loud
you.
and clear. Go ahead. Thank you. Thank you. I know I had the presentation. I don't know if it was uploaded on that side or do I just speak through my experiences?
The presentation is coming on. So you
The
can go ahead
presentation is
and start as it
coming
comes
on.
on.
Okay. So you can go ahead and start as it comes on. Okay. Yeah. Thank you so much. For me, I'm excited to share our experience on what has happened in Makwini. And I'll start off by just introducing myself. So my name is Dr. Mwatha. I'm the Acting Director for Preventive and Promotive in Makwini County. And I'll take you through our journey. And maybe before I start, I'll just give a preamble on where Makwini is located. Maybe we can go to the next slide, please. So Makwini is along Mombasa Road. And in Makwini, we have the 6 sub-counties. And we pride ourselves having the longest stretch of Mombasa Road as one county, covering almost 180 kilometers of the entire stretch of Mombasa Road. Maybe we can go to the next slide, please. So this is the outline of my presentation. So I'll just give an overview of some of the PHC implementations that we have done, the frameworks, and then the achievement and the impact, and then also how we have used data for decision making in terms of policy and PHC programming, and some of the lessons and opportunities in terms of scale up for consideration across board. Next, please. So just to give a context and approach of PHC in terms of the different pillars, when you look at the status of PHC implementation in Makwini, at least we have all the 6 PCNs established and functional. Then in terms of leadership, we do have the TWGs that are established. We also have a PHC focal point person that is appointed. In regards to financing, 100 of our facilities retain 100% of the FIF collections. And this was anchored in 2019 using our Health Act. And that's why we anchored the FIF Act within the Health Act of Makwini in 2019. And part of that allows facilities to have a semi-autonomy to utilize the funds that they raise, and hence, even as we do the outreaches within this facility, it makes it easier in terms of commodity management. In terms of human resource, when you look at our workforce density population, we are currently 10.4 over 10,000 people, and we are fortunate enough to have 6 family physicians who are spread across the 6 sub-counties in Makwini. In terms of service delivery, we have the 6 PCN in place. We also pride ourselves in terms of a very strong community linkage and a very strong community structure within Makwini. In public participation, as you all know, we are one of those counties that have a very strong public participation component, and hence the community engagement also rides on that approach. So we currently have very functional outreaches plus in reaches as well in regards to NCD screening, and this is also riding on the level 1 community structures as well, where we have 240 functional community units within which we have the 3,600 community health promoters. Gap areas within that, we don't have enough gatekeepers within the different communities, and even you'll notice that our community health promoters may not be commensurate with based on the population of almost 100, of almost slightly above 1 million. The other bits in terms of products, so availability of essential commodities, that one has been well addressed, and especially within the lower facilities. Then the other bits and pieces in regards to commodity that now become another common component that we have also introduced through the family physician support to have the NCD commodities within our level 2 and 3s, and hence apart from the essential drugs, you notice that part of the NCD commodities through the support of the family physician are now currently available within our lower facilities. In terms of digitalization, we are currently rolling out the Tibabu and Tibabu and within our lower facilities. So we currently have 242 facilities, out of which 17 of them are hospitals. So we have started off with the level 2s and 3s, rolling out the EMR system, and this is hopefully to support in terms of data management within our lower facilities. And there we appreciate the national team for supporting us in rolling out the Tibabu system. The other bits in terms of innovations and adaptations, we currently have what you're terming as Makueni UHC, which is the UHC component that is riding on the SHA platform, or what we are terming as Mtula Care, to ensure that our indigent or the vulnerable population in Makueni are properly addressed in terms of accessing healthcare services. And then that is also being supported by the NCD screening that is currently ongoing within 35 of high volume facilities in Makueni. Next slide, please. So in a nutshell, that's the distribution of the facilities by sub-counties, where we have tried to tabulate that within this. Yes, so we have tried to tabulate that across the facilities. Next slide, please. So when you look at some of the county indicators in terms of population, we are slightly above 1 million, as I'd mentioned. In terms of facility density, you notice that our initial target of facility density was 2.5. But the beauty is when you look at the distance across each facility, at least we are at 4.5, which is slightly slightly above the recommended 5 kilometers from one facility. But the density aspect is what we had factored in as 2 currently as of 2024-2025 financial year. The utilization of outpatients, as you notice, it is slightly below the target of 3, and this you'll notice, and especially for the level 4s and level 5s. Since October, we have actually had a bit of low outpatient utilization for those hospitals, and this was also pushed by what now you notice with the increase of outpatient within our lower facilities. So when you look at the number of CHPs in our county, we are currently at 3,600. When we do proper mapping based on the villages and population, we are meant to be at 6,000. So currently we are at 62% in terms of CHP rationalization based on the population. Then and that's also now is also informed by the total number of community units, which when you look at that, you need to have 3,300 community units. Currently, we are operating at 240 community units, which is slightly below the target component. In terms of functionalities, all our CHUs are all functional. Number of chairs across the facilities, we have 24 chairs in all the 240 CUs, so approximately 10 approximately one child takes care of 10 CUs. So that's an area that I know definitely in terms of utilization may need to be more adequately addressed as well. In terms of the number of PCNs that we currently have, we have 6 out of the 6 sub-counties and all functional as earlier indicated. Next slide, please. Next slide, because this I've already given an overview. Yes, so we seem to have skipped one. So in terms of establishments, let's next one, please. This is a repetition. So in terms of establishment, this is the processes that we went through, but also to highlight, I know when we started off, Path, which was the supporting partner to in terms of establishment, came with had a budget of 2 million, and they were to establish one PCN using the same amount. But from what we decided to do is to utilize the same funds and rationalizing and maximize the utilization across all the 6 sub-counties. So we were fortunate enough
Dr. Mwatha?
Yes. So part of the utilization, part of the other components that we utilize is we utilize the same funds to, instead of operationalizing one PCN, we ended up operationalizing 6 PCNs across the county. And this is the systematic way where we utilize the funds to do. So initially we started off with the executive component, and this was to allow the political goodwill within the facilities. And then thereafter, we had the stakeholders engagement, and then the sensitization of the CHPs as well, at CHMT, plus the sub-county teams. Then we also had the baseline assessment that was done, then the drafting of the first report, then determination of the findings that was also done to the CHMT and the sub-county teams. Then we also dissemination of the baseline findings to the PCN facilities, plus the CHARs who we utilized, and then the training and sensitization of the MDT team that was operationalized. Next slide, please. So this is part of the multidisciplinary team composition that we operationalized within the county, and all the 6 physicians were all in charge of one of the PCNs. So out of the 6 PCNs, we have a family physician who is in charge, and then now we also onboarded the other specialists as well to have an integrated approach when they're doing their outreaches. Then in terms of composition is as listed: the MO, the nurses, the clinical officers, the CHAs, the health records team, the social workers, the health promoters, the nutritionists, the psychologists, the public health, the lab people, and the OT, and the pharmacist as well. And this is also to support in terms of ensuring that all MDTs are properly sorted out in terms of commodity availability into the lower facilities as they go down. Next slide, please. So in terms of financing of the primary health within Makueni, at least the beauty is we have a budget line, a vote line for PH, the primary healthcare, and that has also allowed even the coordinator to have a working budget in terms of distribution. Then we have also utilized the FIF component in terms of ensuring that the lower facilities will have the necessary commodities. And then now riding on the existing SHA platform in terms of reimbursement for the PHCs. And now we are hoping with the rollout of BRACE, the lower facilities will equally benefit with that fund once it's operational within the county. Then in terms of transition, Taifa Care is what we are currently using, and what we are running with is under Tibabu. Tibabu is the platform that we're using within Taifa Care. Next slide, please. So in terms of achievements, the key achievement is apart from the 236 lower facilities, we have actually now had the entire component of enhancing our capacity building, and then streamlining the work that is ongoing within the facilities, then strengthening the existing infrastructure in terms of equipments that are needed to have the lower facilities functional, then providing the necessary resource in terms of operationalizing the PHC system within the county, and then the other bit is also ensuring that we're documenting every process by research bits. So in terms of achievement, the FIF Act supported where the facilities are retaining the funds, then the CHUs been operational, and then now the Makueni Care, which is now Makueni UHC, being rolled out to support the vulnerable population in terms of both inpatient, outpatient, and other medical services. Then the enablers, I think one of the biggest one that has been a pillar is the strong political leadership and buy-in, and hence the budget allocation to support the PHC within the county, and then strategic partnership. And this is through the partners that we currently are supporting us within the PHC space in Makueni, and the establishment of the PCNs. Then some of the barriers, I think, we don't have adequate staff within the lower facilities. So drawing those facilities out, that becomes a challenge for those facilities. Then the other bit is what we're trying to do is ensuring that despite the challenges of integration, is how do we then ensure that we have proper integration of healthcare services and health systems that we are currently using. And that's why we have had the push of Taifa Care and running it, and powered by Tibabu running in the lower facilities, so that we don't have a lot of disaggregated data components. Then uneven facility distribution, as you had noticed from the previous slide, but it's not distributed based on the population density across the county. Next slide, please. So PHC data, I may not want to revert back, but it's part of what we try to do, try routine data review across the different sub-counties. And then part of the things that we also put as enablers is also to have internet access. And I think this has been properly geared by part of one of our partners who is equally supporting us in terms of availing data. Then availability of reporting tools. And now that we have gadgets within the lower facility, that makes it easier for us. And then a positive attitude of staff, I think that has brought it, has given an enabler as one of those things that have supported. The other bit is on policy. I think the data info, the Makueni County policy in terms of programming objectives, that has supported ensuring that there's adequate policies to support within the rollout within the sub-county. Then the coverage and financing and adequate quality assurance. I think we also identified a focal point person to do QA within our facilities, just to ensure it's not about just offering the service, but offering quality services and being accountable as well as part of the things that we do routinely to support data strengthening of PHC. Next slide, please.
Dr. Martha, 1 minute.
Yes,
Thank
so
you.
part of the learning lessons as listed there. So community engagement, decentralization of finances, then stakeholder collaborations and human rights-based approach to strengthen equity and accountability. Then opportunities for scale-ups is on the digitalization of the PCNs, expansion of the MDT, then enhancement of data cultures, and then replication of Makueni Care model into other counties, as well as those would be the opportunities of scale-up that I would consider. And I would want to end my presentation from there and then pass it back to you, Anjiko. Thank you.
Thank you so much, Dr. Mwatha. You actually covered a lot there in terms of the status of PHC implementation in Makueni County and some of the opportunities there. I think one of the things that I noticed as you were sharing was just the political buy-in, the leadership that is required to make sure that you accelerate implementation, which Makueni is quite clearly demonstrating. And then also not limiting yourselves to we don't have an unlimited pot of resources. So the fact that you truly just prioritize the need to be able to fully implement PHC across a county and looked at making and stretching the available resources you had to be able to do so is really quite commendable. So we changed our agenda a little bit. Thank you so much, Dr. Mwatha. I think one of the questions, I'll encourage people to put in questions in the chat, but one of the questions that I would have for you that we will come back to when we have a Q&A is when we look at how you prioritize your FIF funds. How do you go about that beyond looking at sort of performance-based financing? What are the considerations that the team goes through? What is the process by which you identify how to prioritize those funds that you're retaining at facility level? So if you can think about that as we come into our Q&A section, that would be really great, as well as any additional questions that will come through in the chat. So I also see here that Dr. Lenai is back on. Dr. Lenai, if you're able to, We would love to hear from you briefly before we go into the panel, as the panel gets ready. Would love to hear from you and welcome the start of this webinar series. So Dr. Lenai, over to you.
So thank you so much, each and everyone. And I really want to take this opportunity to appreciate all of us. Want to thank PATH for this great initiative and also thank all the stakeholders from the Ministry of Health, from COG, from the counties, and also from the private sector for this great conversation that is all ahead of us. Definitely, we are now counting like 2 years since we signed the 4 bills into law that are supposed to accelerate universal health coverage in this country. Kenya has been feted at the regional level and even internationally for these great milestones. Of course, re-engineering the Astana Declaration and also all other declarations of universal health coverage. So I really want to thank PATH for leading the path and also giving us the path so that we can be able to have this greater conversation. Thank you, and I welcome all of you on behalf of the Ministry of Health and all health stakeholders in this space as we accelerate achievement of universal health coverage through the right pillar, that is primary health care. This is the Director for PHC at the Ministry of Health, Dr. Lenai. I submit.
Thank you so much, Dr. Lenai. We can see that you're on the road. Thank you so much for being able to join us. I know that you're intending on listening in for the rest of the conversation and that you'll be able to share some thoughts on the chat, also in subsequent conversations. And I think what I want to highlight from what Dr. Lenai has shared just very briefly is that, as we said, we hope to be able to evolve and grow these conversations to beyond Kenya, because as we've said, we really are a front runner. We have other countries in the region really looking to us and hoping to learn from us as much as we can also learn from others. So we are hoping that we will be able to do this at a regional level, starting from Kenya, leading from Kenya, but being able to have these conversations elevated at regional level. So let me go back to the panel that we have set up for us. As I think what we'll have is Dr. Salim come in to give both his reflections as well as closing in terms of what he has insights from what he has heard from all the speakers. So we have a panel for us, and on the panel we have we're hoping to have a conversation that will really talk about how the policy updates align with the realities on the ground and what it really takes to be able to understand, to ensure that policy reforms can be implemented effectively across the country. There's a lot going on, but then how do we make sure that things are not staying and sitting on the shelf and are really being supported, implemented by the healthcare providers who are on the front line, those of us who are working in the community level. So we have a panel that is coming up with diverse perspectives. We have Dr. Mutaha Kangu from the Council of Governors. We also have Eunice Domo from UNICEF and Dr. Joy Mugambi, who is the County Director for Health in Nakuru. So keeping in mind time, they will together reflect on lessons and enablers and measures that can drive PHC reforms forward. So I hope all three of you are available and on. I know that you have stayed on. So I think the first question we want to ask is really directed to Dr. Mugambi as well as Eunice. And I want you to very, very sort of quickly and briefly just speak to maybe just one or two maximum innovations or practices. So examples from the counties that you have worked in that have really demonstrated measurable improvements in the implementation of PHC reforms. So just one or two, and maybe we can start off with you, Dr. Mugambi. And then as you're sharing that, you can also share how you envision these adaptations or these innovations can be scaled up across different countries, what we have to think about. So in just 3 minutes, first, over to you, Dr. Joy Mugambi. Welcome.
Thank you very much. I appreciate this invite and the opportunity to share what we are doing as a county, as well as having been a primary healthcare champion. It's an opportunity for us to learn after 2 years of implementation what is happening on the ground. 2 examples I'll speak about is one, we have had opportunities of exchange learning and learning from each other between counties. When the devolution came in, counties were operating in competition and everyone was trying to do the best in terms of where they are. But with the opportunities of learning from each other, supporting each other, and ensuring that we implement things in the right way, so that if your neighbor is struggling, you're helping them be the best that they can be, so that you ensure that they are in their right track. We just had a forum where we were sharing cross-county learning this week with Transoia, and we've learned a lot from them. They've learned a lot from us. We had an opportunity last year to go to their county and visit them and learn from them. And yes, the neighbor is doing something, but we also can learn from them. The other opportunity we've had in partnership with an organization called Hector has been a dashboard for primary healthcare. We have the DHS, but the DHS is this maze where when you look for data, it's not specific to primary healthcare. You can't specifically say this is primary healthcare data, but we've developed a dashboard which we are piloting within some of our facilities. And we've seen it work. A case study is our Lanet Hospital, which even has managed to raise revenue beyond a level 4 facility. And this is a health center, and the things they are doing are great exploits. And these are great learning lessons that we can learn from. There's so many examples of things being done on the ground, because when people talk about innovations, they are thinking of maybe this technology, big machines. It's not about big machines. It's just the things that we do that change lives. Thank you. Over to you, Anjiko.
Thank you so much for that. Some really great insights there and examples. Eunice, same question to you in terms of the 1 or 2 practices, innovations that have really, you can see measurable improvements, similar to what Dr. Mugambi has shared.
Thank you so much, Wanjiko, and thank you, colleagues, for joining and for this opportunity. I'd want to pick from where Dr. Mugambi has stopped in terms of talking about, sometimes when we think about innovations or practices that we need to, or best practices, we think about technology or big things that are happening. But I'd want to talk about simple adaptations and contextualization that has happened in the implementation of primary healthcare at the county level and what we have observed happening. And this has to do with the process, the approaches, and the structures that are being established to revitalize primary healthcare. And one of the examples is how the referral networks are being formed. We know as Kenya, we have adapted the modified hub and spoke model. And what is expected is a PCN will have a hub and spokes underneath it. But based on the mapping that the counties are doing, they realize then that just having the hub, given the distance or the population being covered, it may not be sufficient to establish or strengthen our referral networks. So counties have gone ahead and established what they call mini hubs, which are now helping to serve the spokes in a better way, and the mini hubs then are connected to the main hub. That is something that is working and is strengthening the referral networks and also how service delivery is being provided. In addition to that, there is a bit of establishment, for example, in one of the counties, of ward practice groups. So at the ward level, just devolving the specialization so that we have teams that can work together to ensure that specialized services are getting to our hubs, to our spokes, using the ward model so that no ward is left behind, and they're able to use the health profiling to ensure that they know where are we having gaps and how can we serve the communities that we are serving better. So that is something that I've seen. I think as a nation, something else that I've seen, and it ties into what Dr. Joy has talked about in terms of data. As a nation, we adapted the vital signs profile, which is using the progression model, a dashboard that helps us visualize both qualitative and quantitative data that would help us see the maturity of primary healthcare. There are some counties, and we know Kenya was the first country globally to devolve that because the progression model was mainly being used at national level. But as a country, we were able to adapt that tool and evolve it to the county level and develop vital sign profiles for all the counties. So there are counties that are using these dashboards and developing them further and updating them. I know it is work in progress, but we've seen them being used as, because they're able to collect data from different sources, both routine information, but also from the other domains in a way that we can visualize and see how we are progressing. How can we scale up this across the counties? I think the cross-learning is very important, is a good practice that we should institutionalize, and also how we strengthen our knowledge management in terms of documentation, and also ensuring that we are integrating implementation research in PHC so that then we are able, as we implement, we can document and we can show what is working and what is not also working, because that is something else that we also.
Okay. Thank you so much, Eunice Dongo from UNICEF, as well as Dr. Joy Mugambi. Please stay on because I will have one last question for the two of you. You have provided some really good concrete examples there, and not just examples, but you've also highlighted how these can be scaled up across different counties. We will make sure that we have this documented, of course, but then I want this to be something that everybody on the call should be thinking about, particularly when we ask for your feedback in terms of how is this a platform that we can use to make sure that we're sharing these innovations, these practices, and that they're not just staying within neighboring counties or within specific implementing partners, yeah? That it is really going across the country, and that counties are really being able to select what works best for their needs and for their communities. So we have also Dr. Kangu on the line. Dr. Kangu, I have a slightly different perspective sitting, at the Council of Governors. From your perspective, which national or county level policy reforms do you feel are the most urgent to create sort of an enabling environment for primary healthcare implementation? Like, if there's anybody who's still thinking about, are we prioritizing the right things, what would you advise? What do you feel is if you can get this one piece right, then things will fall into place? So Dr. Kangu.
Thank you so much for giving me the opportunity. I would like to say that from the perspective of a constitutional lawyer, I have, in the recent past, identified a serious gap in our policy-making systems that is informed by the fact that we hardly think through seriously the linkage between the policies we make and the fact that finance drives policy, and therefore thinking through very well the financial arrangements that would be required to implement the policies that we make. And for that reason, Kenya is a lot of times referred to as a fertile graveyard of very wonderful policies that are hardly implemented. Now, if you look at the literature, you will see that African countries 20 years ago signed the Abuja Declaration, undertaking to allocate about 15% of their budgets to health. And literature shows that only 3 countries in the whole of Africa have at any given time reached that 15%. Kenya is not among them. Now, on the issue of primary health care, in my view, while we may have put these legislations in place, we still, again, did not think through the financing issue very well. And if we preceded these laws with a thorough situational analysis, we would have been able to see that one of the big problems health suffers in Kenya is because its financing is left to the discretion, very wide discretion of political leaders who make decisions on what to prioritize in terms of financing. And so our design of financing primary health care, if you look at the social health insurance act, was that we provided for a primary health care fund. And the question we may need to ask is, does the primary health care fund under our SHA law limit the discretion of the politicians? And the answer is that it doesn't, because the primary health care fund we have provided for under SHA is dependent on the goodwill of the politicians during the budget processes to allocate money to that fund. The Ministry of Health may ask for a lot of money, but the politicians may not see things from the perspective of the technical people at the ministry, and will end up allocating less money to that particular fund. And to my mind, the major policy we should have made is, how do we reduce that discretion? And my view would have been that we should have made a choice that takes away that discretion by simply identifying earmarked taxes for health, including primary health care, so that once that money is raised, the politicians do not have discretion over it to allocate. The money would be already determined to be for health. And many countries have done that. And when you're doing that, you look at consumption taxes that are tied to certain goods, and these are divided into 2. One would be goods that can be consumed by the larger population, including people in the informal sector. So that way, raising money from the informal sector would become very easy. Now, the second type would be what some scholars call the sin taxes, taxes that are aimed at reducing certain sins from being committed. And for example, consumption of alcohol, you impose that so that you may reduce the consumption of alcohol. Consumption a lot of sugary goods, you may impose that to reduce that. And that way you would be able to raise money to address some of these public health issues. We didn't do that, and that still has a major weakness in our law. But a more serious weakness is the fact that for the citizens to access the primary health care fund, they first must be registered and fully paid under the social health care insurance fund. And so, much as we may talk about what is going on in Makueni, in Nakuru, and all that, the reality on the ground is that many Kenyans who cannot afford to pay the contributions under the social health insurance fund are finding it difficult to access whatever little may have been allocated to the primary health care fund. So we need to think through very, very seriously the linkage. We may need to seek to do some amendments to the Social Health Care Act, Health Insurance Act, so that we design a financing system of primary health care, not just primary health care alone, but health in totality, in a manner that fundamentally reduces the discretion of the politicians to prioritize money for health. Thank you.
Okay. Thank you so much. Thank you so much, Dr. Kangu, being able to speak from your perspective. And what I've picked from that is really the need to make sure that policy reforms are go hand in hand with the financing that is required to implement. Those two should not be separate processes. Sometimes the lag is what causes these discrepancies, causes this, as we said, things sitting on a shelf, and then sort of doing things after the fact. So those should go hand in hand. And it's really great that you even shared those insights, because that allows us to start even thinking about the next session, which is specifically on financing, where we will just go deeply into financing and really unpack some of what you've shared. So it's good that you've sort of started planting the seed as we go into that next session. So to all of our panelists, so to Dr. Kangu, Dr. Mugambi, and Eunice Dongo, I want you to share just in 1 minute or so, thinking about all the critical stakeholders that are involved and are supporting the implementation of primary healthcare in our country, whether they are sitting at national level or county level, whether you're sitting at the community level or working in a facility, whether you are a partner who is supporting the priorities of the ministry, or whether you're in private sector. How do you feel, or what would you suggest in terms of how stakeholders can maintain the momentum? So we do have some momentum going on, particularly as I've shared with the last couple of years with some of the reforms, whether they're legislative, whether they're financing, whether it is a general policy framework. What do we need to do to maintain momentum and just make sure that we sustain implementation, and that we don't have sort of gaps, or again, yeah, just that we accelerate and we maintain momentum. Just one recommendation, suggestion that you would have from that you can share. I can start off with Eunice, just the one. Thank you.
Yeah, I think one of the recommendations for us to be able to sustain the momentum and to ensure long-term sustainability of PHC, it would be to make our planning, budgeting systems and platforms more responsive to PHC. Because even with the current level of funding, we still are not able even to measure and track the implementation that is going to strengthening primary healthcare, because it is not even very well defined, or even the budget lines or how it is defined within the systems or the tools that we have, it is not very clear. So we have an opportunity of strengthening those processes, defining PHC well in those processes, so that then our budgeting and planning systems become more responsive to primary healthcare. Thank you.
Okay, Dr. Mugambi.
Thank you very much. For me, working at the grassroots, communities have answers. So any partner coming in, come in, talk to the community, talk to the healthcare practitioners who work on the ground, co-create, co-fund, and then co-celebrate, because this is work when you come in together and you learn from each other, it works better. But most of the times we find partners coming in already having planned themselves, but it is best when we co-create and we do something that's really valuable to the community based on what their needs are. Thank you.
Okay, thank you so much. Dr. Kangu?
Now, one thing I would like to talk about the activities at the local level is particularly when we look at it within the context of our devolved system. And I'll use the example of the Global Fund. I have, in the few years I've worked in health, noticed that the Global Fund approach has been that of money being put in a basket and then distributed to implementing partners. And my experience in the past few years show that when it comes to that distribution, we have not seen serious need to strengthen the health systems in the counties. A lot of times we have created bypasses and given more money to civil society and ignored the county governments and strengthening of their systems. And now looking at what has happened with the Trump in January this year, when the support was stopped, everybody is now rushing to the counties, telling them, can you integrate these programs into your systems? And going forward, to my mind, this is a lesson not just for the government, the civil society, and the development partners, but also the development partners, because we must focus on building systems. And we must agree, I know that when we started the struggle against bad governance in this country, the approach by a lot of development partners was to create bypasses because we had totally lost trust in government. And that is how you can be able to explain the very massive growth of civil society in our country, because development partners were bypassing government and using civil society. And the question is, for how long are we going to do that? When are we going to be ready to develop government systems and trust them to work? If we think that government is not delivering, and for sure I agree there are weaknesses in government, we must face them, confront them, address them, fix them, so that we don't end up in the situation we are today, everybody now telling county governments, integrate our programs and projects into your systems. But when the money was there, you took a bypass. Thank you.
Thank you so much, Dr. Kango. Thank you so much for those insights to our panelists, Eunice, Dr. Mugambi, and Dr. Kango. We do have some, I think we have 1 or 2 minutes. I want to check that Dr. Mwatha is still on. I was hoping that he would still be on. If not, we did have a few questions for him that we will request that he responds to when we share the briefing note. But the questions to Dr. Mwatha was specifically on expounding on the functionality of the PCNs. He did share that in his presentation. All presentations will be shared as well, where he even specifically mentioned about how how they have devolved their specialized services so that so that these MTD members are able to move from hub to spoke and are not just sort of static and stationary, as well as being able to support issues around like the commodities. We will have him come back to speak to some of the details. I think there was a question around the FBO coverage and how those are working and networked with the PCNs. That was a question from Hazel, although he did mention that they have 2 FBOs at level 4 and 23 FBOs at level 2 and 3. So we will ask him to expand on that. There was a question around any evidence of improving PHC indicators in ANC, for example, EPI, maternal health. Maybe Dr. Mugambi, if you're on, could you speak a little bit to, at least in Nakuru County, what you're seeing in terms of improvement of PHC indicators? We will have a specific data session as one of the learning sessions, but just very briefly, in 1 minute, what are you seeing?
We've seen a shift in terms of utilization of primary healthcare. We have a multidisciplinary team headed by either a family physician or a family health clinical officer. They do outreaches and they are able to see clients as near as their homesteads and their households. And we've seen a better utilization of the preventive and promotive services. We added the support groups. Nowadays, we have support groups for the diabetics, hypertensives, and they are supporting each other. They are being able to be supported even to ensure when the MDTs come to their areas, they see them in a more organized manner because it's an organized group. And you know you're going to see them this week. You're visiting an area, you've said you're going to Njoro, and within that area, the support group is ready. The MDT has more ease and is able to package their deliverables, which they require when they are visiting them. And this has enhanced the service delivery. It has reduced the loads within the outpatient and improved the utilization of other services within the level 4 and 5 facility, so that they now enhance the surgical departments, they enhance other services which were being utilized by the primary healthcare clients.
Okay, thank you so much. Thank you so much for that. I think one of the other things I've seen in the chats is we have a Gabriel who shared that we would want to share divergent perspectives on PHC reforms. This is a platform to be able to do that. I think Dr. Kangu has already started by provoking our thinking in terms of looking at long-term improvements and health system strengthening. And those are some of the topics that we hope we can actually get into in more depth and detail when we have the specific theme. So that is definitely something we want to be able to use this platform for, because it is for learning, and learning includes divergent as well as a variety of different perspectives. We do have a couple of questions on details from Makweni, from William, and William Olaka, as well as William Okello. We will make sure that he provides those details in the webinar notes that will come through towards the end of this week or after this webinar. Jacinta, you had a question. You said that you had noticed, you had made a note about the maintenance personnel and whether you have biomedical engineers not present in the MDT teams, and whether that has become a need. And I think that was answered. Typically, they are included as part of the supportive supervision teams, but then as you're saying, suggesting is, you know, that the need to have them embedded fully within the MDT team, I think, is something that various counties are looking at, and one that we could possibly explore in also the further in subsequent conversations when we look at the health workforce. And then let's see, I think we've been able to answer, to just sort of highlight some of the questions. We will, as we said, we will share the presentations and we'll share a debrief note to go with that will come in after this webinar. But I just want to make sure, because one of the things we wanted to make sure to do is to be able to hear from you. And if we can have the presentation come up, and this can be done both on the chat as well as on Menti. We just have 3 very quick questions for you, but the first one is really the one that we want to hear from you. You'll remember from the beginning, we said we want to hear what you want to learn about, what topics and themes, which counties you want to hear from, and what specifically from those counties. Who do you want featured on this webinar series? What do you want them to speak to? What kind of expertise do you want featured during these discussions? And so I'm asking the team to put that back on, the presentation back on, so that we're able to capture that. So the first question is really, and you can do this, you can put it in the chat, share in the chat box if you feel comfortable for everybody to see your suggestions. Alternatively, you can use the Q&A, so that will just go into the panelists. And then we are trying to make sure that we give everybody an opportunity here, particularly for those of you who might be just on your phone. If you go onto menti.com and you are putting the code that is on your screen right there, which is 5634-2185. Again, 5634-2185. And we've also put it in the chat. For those supporting on the back end, if you can put in both the Menti as well as the code. And if you go on to the next screen, just very, very straightforward. Again, I think we will skip this question. We'll go on to the next one because we do want to hear, and we've seen from the chat the question around how to engage even further. So one is the topics, the speakers, and the partners you'd like to see featured in future learning webinars. And if you can, please also identify what specific themes or topics. So if you want, another Dr. Joyce Mugambi to come on, if you could share why specifically, what the particular insight or perspective that would be helpful for us. So I'll just give you 1 minute to do that. So you can do it either on Menti or just go ahead and put it in the chat. We're giving you all the options and we're capturing all of this to make sure that we have a track record of what you want to hear and what you want to learn from and who you want to hear from. So let me give 1 minute there just to allow people to do that. Okay, good. So I like this first one. Somebody's suggesting sessions around PCN performance, specifically outcome indicators and actual performance. I know we have a data session coming up, so that will definitely feature very heavily there. Another one is around how to standardize the PCNs in terms of goals, strategies, and functionality. Topics around sustainable PHC funding. So that we have said specifically the next session, which will be early December, will be focused on all things financing. And then I think that one also has 2 points about successful MDTs in different countries. I too would love to hear how the MDTs are operating in a way that makes them most effective and reaching their communities, the various communities across the countries. Yes, health co-financing, sustainability, topics around data quality. Good, multi-sectoral engagement. I'm really good to hear that because that was one of the suggestions for one of the upcoming themes. Great. Now here we have a specific speaker that has been suggested, Dr. Kitulu. With her priorities around PHC. We have Dr. Ganda from Kisumu to talk about some of the PCN lessons there. Dr. Baraza from CHAC. Health co-financing in the counties. These are some really, really great examples. Thank you for these. Please keep those on. Let me see if there are any that came through in the chat that I have missed out. But I'm really encouraged by this. Okay. We see here best practices in the implementation as well as digitalization. That would be great. I think we had mentioned that we would love to have a specific session on digitalization, a focus on community health, and it says PCN is too constricted and only revolves around CHPs. So expanding that conversation beyond CHPs is the way I'm understanding that comment, but please go ahead and expound more. Let's see if there's any more. Yes, best practices. Okay, so all of these are going to be captured. If you have any thoughts, please just continue to put them in. Let me see if there are any in the Q&A box. There's a couple of points around accountability for the health system strengthening. That the individual who has shared this has said that the take is not on civil society, it is not the UN, it's not external donors, it is us. It's us who need to figure it out, and us who need to be accountable for the commitments that we make. I think that would be a sentiment that would be shared across the board. And then also just to identify what does health system strengthening really mean in our context, not just relying on global definitions. Yes, those are helpful. They are providing guidance, but then are we contextualizing them to our realities and what is going on on the ground? So that is a really good point and something that should be a cross-cutting theme. And yes, okay. So with that, I think the only last question we wanted to ask is around that the best timing for the webinars. We have some options there, but again, if you feel like those options don't make sense, we really want to make sure again that this is not a series of meetings, it is a series of learning opportunities. So what sort of timing do you think would make the most sense? If you can just indicate there, if you have some different view as well, please share on the chat. We would just love to hear from you to make sure that this is really useful for those of you who are joining in. So with those last few comments, please go ahead and share. I just want to reiterate a few things. One, that we will be sharing all presentations, will always be shared after the webinars, as well as highlights from discussion points in terms of key insights that were shared, both from speakers as well as from you in the chat boxes, or when we're able to have greater interaction and more inputs by coming off camera. So we will make sure that as much as possible, we're always sharing the information that is being shared here, so that it is also useful and helpful for those who have not been able to join in, and that they can follow along and be able to join in subsequent conversations. Again, we said we are hoping that we will be able to do this approximately every other month. So the next scheduled one will be the beginning of December, that will be focused specifically on financing. So that will be a financing learning session in early December. You will see a notice around that coming through ahead of time. Again, we are hoping to have a variety of counties always featured. We really hope that by the end of this series, we've covered the whole country. We've heard from every county, everywhere in this country. That's our goal, because everybody has something to share, and we all have something to learn from across the country. With those final thoughts, I want to see if we have Dr. Lanai I saw that he was, as much as he's on the road, he has been following along. Is Dr. Lanai back on to be able to give some closing remarks? Dr. Lanai? And let's see, I know Dr. Gutu had been on, but I see he might also have had to drop off.
So
Dr.
thank you so
Lanai,
much.
thank you.
Thank you so much, each and everyone. Thank you, Pab, again. Thank you, great discussants and panelists who have been able to give this webinar series a lot of, a lot of meaning in terms of really bringing the conversation to the table. Really want to appreciate all of you for this. And very, very important, I think, just speaking from Professor Mutaha Kangu's concerns that we have so many policies and yet implementation is a big issue. I think with the time as we package all these issues that are coming up, I think we need to ask ourselves, how do we take this webinar series to the level of being able to address the gaps that are existing, so that we accelerate the achievement of universal health coverage. And very, very important, I think also, I would like Professor Steele, being a constitutional lawyer, to really also look at how we can be able to edge closer to the hearts of the politicians, so that we can be able to push counties and even national level to really allocate at least 15% of the budget. So I think there's a great conversation. I'm sure with the time we shall be able to get there. And what I can just say is thank you again to PAD, thank you again to the health sector stakeholders for this greater conversation. Let's keep it live, let's keep it moving, and a luta continua. Thank you so much.
Thank you so much, Dr. Lanai. Thank you, everybody who joined us today. We wish you well, and until the next time. Thank you.
Thank you and bye.
Bye.
Bye.